Record. All right. Hello, everybody. Welcome once again to the Penn State College of Medicine Navigating Primary Immunodeficiency Community Health Partner Echo Series. We're delighted to bring you this really important series with our partners at the Immune Deficiency Foundation. My name is Melissa, and I'm with the Project Echo team. Before I get to our regular announcements, let me ask my Echo partner to introduce herself. Jessie?
Hi, everyone. I'm Jessie. I'm an education program coordinator with Project Echo at Penn State, and I'll be helping out with the attendance and some data collection today.
Thanks very much. Okay, on to our announcements. We ask you not to share the Zoom link with anyone, but instead, if you know of someone who's interested in the series, please have them contact me and I will give them the link to register for the series so they don't miss out on any of the wonderful resources that we're able to send out. We ask that during the session you stay muted unless you're speaking. Closed captioning is enabled. If you would like to use that, just click on the CC icon on your Zoom screen. We also ask that if you're able, please turn your video on for the entire session. We love to see your smiling faces. Please do also remember that no protected health information is allowed when discussing your experiences with patients or clients. We are recording the session and we will make recordings available to you as well as all materials after the session via email, and you'll receive that tomorrow. If you'd like to request a recording, just respond to that email and I'll be sure and get that out to you. We do ask you also to please respect the fact that no personal medical advice can be given during the session for you or your patient or client. Our partners at the Immune Deficiency Foundation have extensive and excellent resources and information on their website. That link is also included in the post-session email, and I'm going to put it in the chat here, as I always do. If you haven't had a chance yet to take a look at that website, I strongly encourage you to do that. In the spirit of ECHO's all teach, all learn education model, we will all be on a first name only basis during our sessions. But most importantly, what that means is that everyone is here to learn from one another, and that includes participants and panelists alike. And as we've been doing throughout the series, I'm going to ask you to use the chat only as a last resort. With so many people in the group, it's really easy for the chat to sort of overtake the session, and it makes it difficult to keep track of what's going on in the live session as well as the comments being put in the chat. So if you would, please just unmute when you'd like to chime into the conversation or use the raise hand icon and I will get to you. If you are logged on with a phone number or have other people joining you, would you please send a direct message to Jessie or myself to let us know for the attendance records? Okay, and we'll begin our session today with a flash talk on transitioning care, and that will be presented by our guest speaker today, Dr. Kenneth Paris. Following his talk and any questions you may have for him, our experiences and challenges will be shared by Sumathi Ungar, and I will be facilitating the sessions for the series. So let's move on to some introductions. Since we have so many people, we'll just ask our panelists and guest speakers to introduce themselves. And let me begin with Ken.
Good morning. My name is Ken, and I'm a patient with common variable immunodeficiency. I also serve with IDF as a Get Connected group leader that is a support group for other patients with PI in Texas.
Thanks very much. And I just realized we have two Kens. I'm sorry about that. I keep forgetting. I'm going to get to our guest speaker will be our finale for the introductions. So let's move on to Diana.
Good morning. My name is Diana, and I am the mother of a child with PI.
Thanks very much. Megan.
Hi, everyone. My name is Megan Messick, and I'm the Director of Education at the Immune Deficiency Foundation. It's a pleasure to join you all this afternoon.
Thanks very much. Paula, are you able to unmute?
Hello. I'm Paula. I'm one of the immunologists at Penn State Hershey Medical Center. It's a pleasure to be with you here today.
Thanks very much. Paula is in clinic, so she'll have her video camera turned off. Colleen?
Hello, everyone. Thank you for being here. My name is Colleen Brock. I'm a registered nurse and the manager of medical programs at the Immune Deficiency Foundation. I also have two young adult with PI, and I also have it myself.
Thanks very much, Colleen. And Ken Paris.
Morning, everybody. I'm Ken. I am a practicing allergist immunologist at LSU Health Sciences Center in New Orleans, Louisiana, and at Children's Hospital, New Orleans. And I take care of patients from birth all the way into adulthood and beyond with various immunodeficiencies or immunodeficiencies in those types of patients.
Thank you so much for being here and for this talk. So we'll go ahead and move on now. I'm going to share my screen. And we'll go through our introductory slides. There are disclosures. And then Ken, whenever you're ready, Ken Paris, go ahead and take it away and just let me know when you'd like me to advance the slide, please.
Thank you so much, Melissa. So today I was asked to speak a little bit about the transition of care in patients with primary immunodeficiency. And you'll see throughout the talk, it will only be about 15 minutes. What I really want to do is just present concepts that we have to deal with when we take care of patients, like I mentioned, all the way from birth into adulthood and beyond. Next slide. And so we have basically 4 objectives today. First, I want you to recognize that there is a significant need for the transition of care of patients with immunodeficiency from pediatric to adult physicians. Unfortunately, though, there are some barriers to transitioning that care, and we're going to hear about that both in my talk as well as in what Sumati might mention when she talks to you soon after me. We'll talk a little bit about the importance of shared decision-making among the patient and the healthcare team when you make that choice to transition from pediatric to adult physicians. And we're also going to understand some of the challenges of transitioning care at the various life stages, for example, adolescence or the transition into elderly or Medicare population. Next slide. So for the purposes of just a very, very brief review and to better understand why there's a need for transition into adult care for patients with immunodeficiency, let's just review for 1 minute what primary immunodeficiency really is. It is an inborn or inherent defect in our immune system. And what that means is that it is almost, if not always, genetically based. Patients are born with some sort of gene mutation that impacts their ability to fight off infections and mount normal or protective immune responses. Over the years, we have made huge strides in the way and the ability that we can make a diagnosis of primary immunodeficiency. And there are now hundreds of individual diagnoses which are classified in this overarching diagnosis that we call primary immunodeficiency or inborn errors of immunity. And you might see either one of those words to describe patients with this disorder. Even though there are hundreds of different diagnoses and probably thousands, there is a common theme among all of them. Patients with immunodeficiency are vulnerable to infections due to inherent defects in their immune system. That occurs across all the different diagnoses. But what I like to think about is that there's also like an uncommon theme, and that is that each individual diagnosis may have some unique or unpredictable comorbidity, or they may make someone susceptible only to one unique type of infection. So each one of the patients that you might see in a clinic or a health unit or in a school has immune deficiency, but they each have probably some unique susceptibility to infection or a unique need in regards to the care that they receive. Because these are all genetic in basis, the majority of these kids or these diagnoses are diagnosed in children. But for some reason, which we don't completely understand, they actually can present a little bit later into adulthood. it is not uncommon for patients to present with their first real manifestation of these disorders in their late teens or early 20s or even beyond. And even though I talked about it being, genetic in nature, which typically means that it's an uncommon diagnosis, it actually may occur more common than we think. And it may be as frequent as 1 in 2,000 patients in the general population, or much more rare in the range of like 1 in 100,000 or more patients. Next slide. Okay. So why do we need to transition care in patients with immunodeficiency? I mean, clearly I mentioned that it is genetic in nature, right? And so it affects infants, but it also affects adults. And it has a lifetime impact on their health. So infants, adults, and beyond. The other part of patients' care with immunodeficiency is that there is a need for long-term treatment. There are some disorders which can be diagnosed early, but then the management is either quite simple or doesn't really need much individual care at all. Immunodeficiencies are vastly different from that scenario. Patients with immunodeficiencies typically require lifelong therapies for immunoglobulin, for instance, which is quite complex to administer. Patients with immunodeficiency might require very complex care with biologic medications that require constant monitoring. And so there's a need there for long-term relationships with physicians. Because I mentioned they're genetic in nature and quite unique, patients with PI often have comorbidities that affect multiple organ systems, and patients need to have relationships with multiple subspecialists, an immunologist, maybe a rheumatologist, a pulmonologist, a gastroenterologist. And so they need to be able to see all of those physicians, typically within one healthcare system. The complications that we see in patients with primary immunodeficiencies can also change over time. They can, like I mentioned, develop during their lifespan. One unique aspect of these disorders is that typically the management of these diseases is based at tertiary children's hospitals after patients are diagnosed early in life. And those hospitals might have restrictions on the care that the physicians provide to patients. So in our hospital, for example, in general, there's a limitation up to the age of 21. But sometimes we are able to see patients for much longer than that, into adulthood. And I even have patients I've managed into their 70s and 80s. For you that may not realize this, immunologists are actually trained to care for infants with allergy or immunologic disorders, and also adults. So there are going to be some patients with immunodeficiencies who keep their same physician, their immunologist, from birth all the way into adulthood. But because, like I mentioned, there's some restrictions in certain healthcare systems, it's frequently necessary to transition care to an adult physician. Next slide. So here is a brief summary of the components that we need to consider during the transition of care. I'm not going to talk specifically about each one of these. I think maybe that's best served in the conversation after we wrap up this session. But we need to think about who the immunologist is going to be when we transition from pediatric to adult medicine. Is the patient going to need a new primary care physician? Do they need to go from pediatrician to internal medicine physician? Or will they stay with their family medicine doc, who also has been trained to care throughout their lifetime? Do they need new subspecialists? Do they need new medications that may be approved only for certain age groups? Do they have a specialty pharmacy that's only located in one state? And in the transition into the college years, they move out of state and need to find another person to supply, for example, their immunoglobulin infusions or their biologic medications. On the same line of thought, is their immunoglobulin replacement site of care going to change because their college, for example, is in a rural setting without an infusion center nearby? and they're going to have to transition to do those infusions by themselves. Will they need, for example, I just mentioned, to change from intravenous immunoglobulin to sub-Q immunoglobulin, which is a whole nother conversation that we sometimes have. And then do they need to keep their own records, like paper copies, to move from place to place? Because the electronic medical record at one location may not actually connect or talk to the electronic medical record at their new location where they're going to receive care. Next slide. And so I like to think about the different barriers to transition and who might be, quote, to blame or responsible for those barriers. So for example, there are patient barriers, right? There's a fear of a new network of care providers who they may never have met before. Parents may refuse to sort of let go of control of their child's health care. That child is now becoming an adult, and it's difficult to give up, that type of control. There's changes in the relationships between patient and healthcare systems or healthcare teams. Children's hospitals are very involved in the care in patients. They take responsibility for making sure that the patient is going to come for their appointment. I'm not so sure that happens in the adult clinic world. If a patient misses an appointment, they may not get another reminder call or somebody that's calling to say, hey, you need to come in. That may just be a no-show and no follow-up in a big adult healthcare system is made. I mentioned a little bit before about the poor communication or transfer of records from one system to another. That's a little bit better nowadays, but even now, there's times where I don't get to see the old records in a patient who transferred into my healthcare system. Patients may move to a location where there is a dearth of subspecialists familiar with a certain disease. Not everybody moves to a big city like Philadelphia, Los Angeles, Atlanta, where there's lots of academic healthcare centers. If you move to a rural area in Iowa or the western part of the United States, there may be no specialized pulmonary clinic familiar with bronchiectasis or some of the other comorbidities that we see in patients with PI. And then there's also some changes in the patient-clinician dyad. For example, I often think about my patients as, patient plus parent interacting with me. But in the adult clinic setting, it's often a patient who's an adult and the physician. The parent becomes sort of out of the picture because they may not be around. Next slide. And then there's some clinical barriers to the transition of care. There are a few guidelines specific to care transition in the disease that we're talking about today, primary immunodeficiency. Some centers have come up with plans and guidelines of how to do that. For example, University of California in San Francisco has a specialized transition clinic for PI, but most of the centers around the country and definitely small providers don't have a plan that will, help physicians transition care to the adult world. There's inadequate or bad communication sometimes between systems and the providers and then the patients. And of course, there's inadequate resources for young adults with chronic disease. And then this affects all members of the healthcare team. Pediatric clinicians, I'll be honest, sometimes lack the confidence in our adult colleagues who may be a little less familiar with the management of some of these diseases. Pediatricians are very protective of their patients, and we realize that sometimes it's hard for us to let go. I kind of want to keep patients in my clinic into their late teens, early 20s, and beyond. I know the family and I know what's happened in the past, and it's just hard to really give up that relationship. Unfortunately, payers are always looking for ways to stop or delay expensive therapies. And that transition period is a really common target for payers to start to maybe deny or require new prior authorizations for some of the very expensive therapies that we use in patients with immunodeficiency. Next slide. And there are some challenges, right? And those challenges are related to the issues that we see in all adolescents. They feel invincible. They have a lack of interest in their overall health compared to their lifestyle and activities. They'll probably choose to go out with friends before they say, I really can't. I need to stay home and do my infusion tonight. They'll pick the football game on the weekend or going out with friends before they say, I don't feel so good, or I'm not feeling like I want to be around a big crowd. They'll take that risk and, maybe get sick because they're exposed to lots of infectious agents. But they also they have this need to fit in. They don't want to, miss those important activities during a very, critical developmental stage of their life. Unfortunately, the need to do all of these things leads to a lot of depression and anxiety, and that can impact the choices that they make. They also need privacy, and I think that can really be both a positive or a negative impact on the transition. So from a positive standpoint, that need for privacy may spur a adolescent to say, you know what, mom, dad, I can do this on my own. I kind of don't want you to come to clinic today. I'm 17 or 18, and if it's okay with you, I'll do this today on my own. But it can also have a negative impact. So that need for privacy may prevent a young college student from doing their infusion in the dorm room because they don't want their suite mates to know that they have some sort of medical issue. They make bad choices or sort of uninformed choices because they have minimal world experience and also unrealistic expectations. And there's an overwhelming amount of change during this time. You can imagine between the ages of like 15 and 21, they get new relationships, they get girlfriends, they get boyfriends, they apply to college, right? They move away and their old friends become, people they knew in the past and don't connect with anymore. They have new people that they might have to disclose their diagnosis to, but they don't necessarily want to. They move from one state to another. Some people move out of the country completely for their higher education. So lots of these things can impact the choices that adolescents make. Next slide. And so I've talked about this in other venues, but shared decision making is really important when we do these transitions from pediatric to adult care. And this is just one model of the way that you can do transition or shared decision making in this regard. This model starts, and there's really 4 different sections. So it starts with team talk. That's where maybe I would have a conversation with a parent and a teenager just about the concept of the need to think about the transition from my clinic to my colleague's clinic at the adult hospital downtown. I might give them some options in this next part of the model where I can say, hey, if you want to, we could transition over to my colleague, Michelle, who works in a clinic right next to the hospital and uses the same EMR. Or you could, if you wanted to, go to a friend of mine who has an office out in the community closer to where your community college is going to be, right? So there might be a little bit of back and forth about the different options that you have for that transition. Eventually, though, we need to make that decision, and that's where we would have some really sort of hard conversations about what that might mean and how your care might change. So that's the decision talk, where we're going to actually finally come to a decision, and you're going to choose one person to be your immunologist or another healthcare system to take over the care of your immune deficiency. And what I always tell people during this whole process is that any one of these points we can stop. And even though we've made a decision, we can back up and go to the beginning, right? Decisions aren't necessarily always final. And if something doesn't necessarily work for you, let's talk about it, have that team talk again, go through decisions, and then make a new one, because that might be better for your overall care. Next slide. And then finally, I want to talk just for a minute on the challenges of aging gracefully. Patients with immune deficiencies become elderly patients with immune deficiency, and there's a transition from commercial payer to Medicare and new limitations in regards to the coverage of all of those therapies I mentioned earlier. And it's very important for those patients to have paper copies or even electronic copies that they own and control of their original diagnostic tests, their pneumococcal antibody titers that were measured on 2 occasions, potentially some of their lymphocyte numbers to justify their diagnosis, and if possible, their genetic testing results. All of these things can be super important during a time where Medicare may start to deny payment for some of their very expensive therapies. The next slide. I'll wrap up just with this list of resources that we'll provide to all of the listeners after today's talk. There are multiple ways that we can get this to you, either via email or on the IDF website. And with that, I'll wrap up.
All right, thank you so much, Ken. A lot of wonderful information, and you'll all get all of the slides with the email I send you tomorrow. Any questions for Ken before we move on? He gave us a lot to think about, and some of that sounded familiar from our last session, which was great. We talked a lot about transitioning to college and some of the different options available. Any questions for Ken? Go ahead, Colleen.
Sorry, I have a question. If your immunologist is at a children's hospital and they see adults, what happens if it is, let's say they need to be admitted, they've been in a car accident or something that's not immunology related? I know for my children as a young adult, if it's infectious related, they can be admitted to the children's hospital, even as an adult, but they have been told if it's non-infectious related, they can't be admitted. So how does that then affect who you choose as you age up as to who is running your care?
That's a great question, Colleen. So it is an issue, especially like you said, at children's hospitals, and that's due to liability of the hospital in regards to having an adult in a facility which may not have adult ICU trained nurses or a care team who's familiar with, running if you needed it, a code on an adult patient with lots of comorbidities. We're allowed to see patients in our outpatient clinics of any age, but when we admit at our hospital, there are limitations in regards to who can be seen, and we would need to get approval from that, from the administration of the hospital for that admission, and that's usually what happens. It may spur the decision to transition care to another immunologist within that healthcare system. So there might be a team of immunologists. For example, I'm at Children's Hospital New Orleans. My colleague Michelle is at University Medical Center downtown. I hold on to a few of my patients who I've had relationships for a long time. But if they needed admission, they could go downtown, and Michelle and I could collaborate in the care of that patient. And I see Sumati, nodding her head because I know she's a hospitalist. So that's sort of what can happen, in the perfect world. But you're right, it can be a huge issue. And that's why we need to transition, right, to adult care, or at least have somebody that that can take care of you if you need it in an adult hospital.
But I'm assuming that you would recommend, as people age, to have that conversation before it's needed, correct?
Ideally, yes. Ideally, yes. But remember, there's two parts to the healthcare team in a patient with immunodeficiency, right? There's the immunologist, and then there's the primary care physician. So in some cases, that immunologist is the best choice into adulthood because there is no other adult physician who's comfortable. So you really, every situation is a little bit different. Just because you're turning into an adult, it doesn't mean that you should transition to an adult allergist immunologist, right? You need to make sure that that person is comfortable. I kind of alluded to that we don't always trust. So I know a lot of the people on the call today are maybe not familiar with our specialty in allergy immunology. So we are trained in allergy and immunology. And in our world, sometimes we call ourselves big A, little I, where you're primarily an allergist, but you do a little bit of immunodeficiency. And then you have little a, big I. And that's where you know all the allergy immunology care, but your primary, passion is the care of patients with immunodeficiency. And that's what I do. So you kind of need to find those little a, big I's to take care of your child as they get older.
Great, thank you very much, Ken. Any other questions?
Is
All
there
right.
a resource available readily for patients? For example, there's a list of physicians where we can reach. Is there a ready-made list where patients can see, oh, this is an adult care physician. I can actually transition in this state to this physician. Because right now I have a son who's 25, and when he went to Maryland, oh God, it was just crazy to find people. And it would be nice to have a website where we put in state, city, whatever, and there's a list of adult immunologists. It would be a good resource for our families to have.
I see Colleen is going to answer that.
The Immune Deficiency Foundation actually has that resource where you can go in. It originally started with immunologists throughout the country, Alaska and Hawaii, and you can put in your zip code, how far you would like to travel. But we have expanded it to include all kinds of clinicians. And one of the things that I'm doing is trying to grow and grow and grow that beyond just immunologists, because as Ken said, we need gastroenterologists, we need ENTs, we need pulmonologists. And a lot of people want to see somebody, they may not be the immunology expert, but at least they have some knowledge, or maybe they take care of some patients with PI and pulmonary issues. So that is on the IDF website.
Thank you, Colleen. If you haven't checked out that website, I'm telling you, you have to get on there. There's just great stuff.
I already started going on there, but I will complete it afterwards. Thank you, Colleen.
It takes
Oh, you're welcome. Dr. Paris is on there, and so is Paula.
All right, just for the sake of time, if you think of any more questions, please put them in the chat or raise a hand, but I'm going to move on to share my screen for Sumathi because she has an excellent experience and challenges and questions to share for us. Let me get that up, and then Sumathi, whenever you are ready, go ahead.
Sure. Yes. So a quick introduction to where I am coming from. I am the mother of a 25-year-old who has Wiskott-Aldrich syndrome, which is a very rare immune deficiency disorder, and I run with the Wiskott-Aldrich Foundation. So about 5 years ago, at that time, the 32-year-old physician called me up. He's the father of three. He called me up and said, hey, you run this foundation. I used to have Wiskott-Aldrich syndrome, and I had bone marrow transplant, and I want to help out with the foundation. So this young man, obviously, it's a genetic disorder. He was born with it. And at the age of 3 years, because low platelets is a part of Wiskott-Aldrich syndrome, the physicians had done a splenectomy on him to improve the platelet counts. So his counts got better. So they said, fine. But by age 9, his health started declining. So the doctors went ahead and did a bone marrow transplant on him, which was very successful. And he was technically cured of his Wiskott-Aldrich syndrome, which is an immune deficiency and a low platelet disorder. and he did great. So he continued following with the bone marrow transplant clinic as he was supposed to. He would go every year, but not every year, he said. Sometimes he would go every other year. And he vaguely remembers that around age 9, 10, when he had the transplant, the doctors discussing with his parents, mainly, he just happened to be in the room, that just maybe he might be infertile as a result of the bone marrow transplant. But that was it. He said vaguely, that was the vague conversation that I remember. So he continued going to the bone marrow transplant clinic until he was 21 years old. And after he was 21, by then he was graduating from college and going into medical school. And just as Dr. Paris, that was a great talk, delineating all the challenges, the different factors that have to come together. Busy young man, as Dr. Paris said, hey, and nobody told him otherwise. So he said, oh yeah, I'm cured. I have no problem. I'm a full-fledged great adult. I can just go on to do my life. So he went on with his life. He just went to his PCP, who did not know otherwise either. So, and he was having a great life as far as he was concerned. Next slide, please. So the challenges with having a splenectomy is the spleen is an organ that is part of the immune system. It's an important part of the immune system. And when we don't have the spleen, sometimes bacteria can get into our blood, especially certain kind of bacteria like pneumococcus for Wiskott-Aldrich syndrome, and patients can die of a septic infection, a sepsis in the blood. And this is true for Wiskott. Even if you're cured of the disease, you can have it. He didn't know this. Now, remember, this is a physician. We can say he should have known better, but he didn't. And if he didn't know, how are the other people supposed to know these things? Is the challenges I'm looking at, and I'm like, wow, he didn't know, how are the others going to deal with it? He didn't know, so he stopped taking penicillin. So you take penicillin every day to prevent that infection. He stopped taking it because he felt good and he was cured. He was fortunate he didn't have an infection, but he could have, because we've had other patients die of sepsis. Also, after splenectomy, as Dr. Paris explained, some people need extra vaccines like pneumococcal vaccine to prevent these infections. He did not receive all these vaccines. Went on to be a physician. He got married, and then he found out he was infertile. And then at that point, he's like, oh yeah, they vaguely told me he might be infertile. But nobody had checked him. And obviously they went through a lot of trauma, because at that point he found out that he was infertile. It was not earlier. He didn't know earlier. He didn't realize it earlier. And then when he called me, he said, I want to be a part of your foundation. I want to help out. I said, hey, what's going on with your life? So he tells me all this. I said, so, hey, have you got all these vaccines? He's like, no. Are you seeing a BMT doctor? No. I'm like, how come? He said, nobody told me. I said, what do you mean? You cannot do this. You have to go back every year. He says, oh, really? I didn't know. So he said, fine, I will go back and make sure I'm checked every year. But obviously, there was a lack of transition of care for this young man, a knowledgeable young man. And I have to say, he was being treated in one of the best world-renowned medical center, wasn't a podunk medical center. He was being treated, and there was a lack of transition of care when the ball got dropped, when he went from childhood to adulthood. And this could have resulted, it did result in some challenges in that the infertility, it could have been handled in a much better way. There was a lack of communication when he got older as to what he should do, because bone marrow transplant patients can have lung problems, they can have secondary cancers, they can have other issues related to the transplant, which should be checked every year. And this was not communicated to the patient. And if the sad part is, just before I spoke to him last week, and I said, hey, so did you get all the care? He said, yeah, I went to the immunologist, and the immunologist did all my checkups, and he thinks it's fantastic. So I said, did you go to the transplant physician? He said, well, I didn't know where to start. I didn't know who to write to. So I didn't go. This is 5 years ago that I told him to go. He's a physician, and he's telling me I didn't know where to start, so I didn't go. So I got mad at him. I'm like, what are you doing? So I told him, okay, you need to write to your pediatric transplant physician. He's like, yeah, I didn't think about that. So these are some of the challenges. If a physician is having these challenges, What about the other patients? So let's look at the challenges. So what should we do? We all have children. I have a child who became an adult, and we had a terrible time transitioning him when he left college and went to work in another state. And partly for the reasons Dr. Paris said, the pediatric doctors here did not want to let him transition into another state. They said, we'll take care. I mean, seriously, they said, don't worry, you can just call me, we'll take care. And so, and what point does a child start taking an active role? Is it 12? Is it when they become an emancipated minor? When should we start talking to our child? As a parent, when should we start? And I can tell you, as a physician and a mother, it's difficult, like Dr. Paris pointed out. I don't want to give up the care of my child. It's kind of terrifying. He has a life-threatening disorder. I don't want to give up his care. What time do we do this? What time when the patient has had a transplant? When do we talk about infertility? How do we find out an adult immunologist? What can parents do to assist the child to get the transition? And what does the adult need to know when transitioning? Oh, this is like Dr. Paris once again pointed out, the older you get, it's a different transition to skilled nursing care. And from the insurance issues are always all encompassing and looming for us. So with that, any questions? I'm happy to answer questions. And I'm sure Dr. Paris and others will jump in too.
Thank you so much, Sumati. So let's start with our participants. Virginia put a comment in the chat about Children's Hospital in Cincinnati. Thank you for that. Any questions or some more information you'd like to know from Sumati? There's a lot of questions here. So you're welcome to start somewhere or ask a question of your own. I think I'm going to leave the questions up just for a little bit so we get a chance to sort of process them. That's all right, but it makes my Zoom screen smaller. So holler if I don't see you. If you don't have questions, do you have some suggestions? Where would you have started? Any thoughts from any stage? 9 years old, that's awfully young to remember somebody mentioning you might be infertile. I don't know many 9-year-olds that think that far ahead. But all the way through from teenage to adult, what thoughts do you have?
I mean, I can tell you, going back, I wish I had transitioned my son. I wish maybe I'd started at age 12, telling him his medical story. And my thought would be at age 12, I should have started training him better to ask questions of the physician and take more control of his medical care. Other people with experiences, I would love to hear.
So Sumati, I was just going to comment about the story that you said about that physician. You know, he obviously was at a bone marrow transplant center, right? Which you think would have excellent care. And I'm sure the physicians, they mentioned the infertility issue to the family and to, the patient. And they probably thought they had done their job, right? They said it. But what patients hear, especially teenagers or adolescents in the conversation in a physician office, is often something completely different. And we need to be mindful of that, right? So even though we think we've told the patient, we've given them the risks and benefits, et cetera, they maybe didn't hear it, or they heard something, they heard the word what maybe could be infertile, right? And that's the word that he focused on, was maybe, not infertility, right? So we gotta be real careful when we do this transition. We gotta recognize that, like I mentioned in my talk, adolescents have a very different perspective on their role in their overall, medical care.
Yeah, it's a good point. When you're given an overwhelming diagnosis like that, I'm sure parents too just can only take in so much. Megan, go ahead.
No, I think it's something Ken pointed out. I mean, first I recognize this is an individual had a level of privilege, both a level of health literacy far and beyond the average person. And that was probably the overwhelming part of this is a person with a extraordinarily high level of health literacy. That is not our average patient that we work with, but communication is so important. We hear we have so much coming at us in medical appointments. How can physicians, how can the healthcare team, how can the patient work collaboratively to document things and keep that medical history? Have electronic medical records helped us? Yes. Are they sometimes a burden and hindrance? Yes. So how, like, even now we're in a more digital age than 37 years ago or 30 years ago, but how is a family provided the information that says this is the potential long-term outcomes of BMT in Wiskott-Aldrich syndrome? And how, like, what is the, looking at the continuum of care and having those resources available. I know the IDF has done some incredible webinars and things on transitioning care, but it's like you have to have that history. And to Sumati's point is share it with your child. Like at some point you have to they have to own their own story. It's their story and their medical history. They have to be comfortable with being able to even communicate it, even the basics at a certain age. So those are my reactions.
Excellent points. I'm so glad you brought up the fact that this was someone with a high level of health literacy, whereas many people do not have that, or a health background, or feel comfortable even asking questions of physicians. So it's good for us to always keep in mind. Thank you. Go ahead, Colleen.
I love our pediatricians starting at the age of 5 when the kids start kindergarten, when they go in for their physical. If they are on medication, they had to know, he would ask them, what are you taking? Why are you taking it? What does it look like? What is it for? And how much do you take? And they had to answer. They had to know every medicine they were on. Now, some kids aren't on a lot of things, so it's somewhat simple, but mine were on several things. And so they would have to know the name of their product. They would have to know the name of the immune deficiency. And it kind of, you could see that they were proud when they could answer those questions. Or they would look at me like, I forgot the answer to that one. And, he would encourage them. And then as they got older and older, I would take the position of, I'm going to sit back. You talk. It's your body. You know how you feel. I don't have a clue. But I'm here if you forget something or need a nudge of a reminder. So they would kind of go through, this is what's wrong, or this is what's been going on all year, if it was a yearly checkup with your immunologist. And then they would look at me and go, did I forget anything? So it was their appointment and they took ownership of it. But I was sort of the security blanket. And that really worked in transitioning from not wanting to speak and sort of looking at me like, I don't want to talk to him. I don't want to say anything, to them building confidence and being able to say, I've had 7 sinus infections. I've had 2 pneumonias. I've had whatever. And just building that, this is bothering me or this is bothering me ability.
Yep. Excellent point. It sounds similar to what Susan put into the chat as well. Children should be included in decision making. Laura, go ahead.
Hi, I'm also a physician with a young adult son with PI. And one of the things that we started with, even when he was much younger, was going over questions before the appointment so that he knew that he always got first shot at his questions, but I would tell him some of the questions I had too. And he could choose whether he wanted to ask any of mine. He didn't want any of them. And the biggest thing in that for me was, if we didn't get to my questions, if they weren't urgent, they waited until the next appointment. It was his appointment to run with me there to help him. And I think for him, having the discussion ahead of time was helpful in terms of organizing his thoughts. And yes, he rolled his eyes at having the discussion as a kid, but he always managed to do it. and he could do it. I would start offering it to him a couple days before the appointment, right up until we are driving to the appointment. And he usually chose we're driving to the appointment. But the discussion at least occurred. It had given him a chance to process and think through his questions and then also look at mine. And now we basically, his physicians have come to view us as a team, and the leadership has flipped from me leading the team to him leading the team. But we've been able to maintain a very close relationship so that we can interact before appointments and also after or during if there are questions. And that, I think, has given him a sense of empowerment because he knew he's in charge, even if I was going to be the one they would look to. And it also gave him an important thing when you're a physician is we would just tell the physician, talk to him first. And if the physician and I would slip into medical speak, he could simply raise his hand and remind them just with a hand raised that we need to change our discussion to a more comfortable level for him.
Yeah, those are excellent points. We've talked about self-advocacy, I think, through the entire series. So good to start young, despite the eye rolls. And there's something about those car rides that seem to get kids talking. Ken, go ahead.
So I was just going to comment that in our institution, at our in our electronic medical record, which is Epic, there's a functionality turned on where if the parent has access to the child's chart as their proxy up until the age of 15, at 15, it turns it off. And they're forced to restart their access, and it forces the parent to realize that the child now, because they're technically like this age that can make decisions for themselves in some ways, that they have to ask the patient for permission for proxy access to the electronic medical record. So it sort of forces at least a little bit of that conversation about transition of care and taking control of at least parts of their medical record. And then the parent and the child or the adolescent both have access to their EMR data, the clinic notes and results. So it sort of forces the issue right around the age where we typically think it's the right time to do so.
That's really interesting. Go ahead, Megan.
One thing I think we haven't touched on that is important for parents, and really I don't know who it is, but to talk about with their children is health insurance. Because it's a hard subject because it's a financial matter. And it's how do kids understand, we do have what type of, we have insurance. But when you get to 18, 22, maybe you're graduating from college, is that transition of your first job. I remember it was overwhelming. Now, my first job was my first full-time job was in 1998. The world was a lot different with $5 copays and $6 a month, $10 a month premiums. But you have to speak to your kids and understand, okay, the deductible you have to have that financial literacy, and that insurance literacy becomes very important. Flexible spending accounts, health savings accounts. And that is like a whole nother genre out of topics outside of the medical component of living with a medical condition, but it's increasingly important to understand that as you age and care. And then the transition to Medicare, that's a whole nother complete difference.
Right, exactly. Big, complicated systems to learn at both ages, kind of starting in and as you get older. Go ahead, Sumathi.
Yes, 2 points to Megan in relation to what Megan is bringing up, important points. So eczema is a part of visceral syndrome. And just last week, my son called me and he's like, wow, CeraVe is so expensive. I've been buying this and buying this. It's over the counter, but it's finally hitting his pocketbook. And he's like, wow. So this is over-the-counter stuff, and his other medications, forget about it. I mean, it's really crazy, but it's important for them even to know that the stuff we just go to our grocery store and pick off the shelf, they can be pricey.
Absolutely.
So, yes, that was one point. The second thing, with the previous point that you had brought up, Megan, was very important, and it's something we grapple with our patients. How do you condense all of these medical records? My son has had problems since he was born, and he doesn't remember anything. So what we, and especially when you've had a transplant, it's a whole other ballgame. So what we've been asking our patients to do is to ask their physicians when they transition to adult to give them a summary. 2-3 page medical summary, and what is the follow-up needed? So if you need pulmonary function tests every year, or you need it every 5 years, or echo every 5 years, whatever is needed. So we have begun asking them, can you give me a summary of what happened in my life? So this is something new that we've started. We're hoping that this can encourage transition of care and help not just the patient, but it can help the adult physician who's taking over.
Absolutely. Thank you so much. Go ahead, Megan.
I was making sure it was me, Megan, or is it Megan Ryan? Which one? Did you have yourself?
Two Megans, Megan Messick.
Thank you. Something I want to talk about too that I think we bring a lot of value to when it's our older community members, but don't always remember when it comes to our younger community, is also the value of peer-to-peer learning. We do peer-to-peer learning, peer-to-peer empowerment and advocacy in the older subset, but sometimes forget that younger people's shared experiences bring a lot of value, confidence rearing, that they can learn from each other. So for those who are not familiar with the Immune Deficiency Foundation's programming, we do a lot of virtual opportunities as well as in person for there to be that teen to teen, that young adult to young adult dialogue, and to allow those peers to be leading the discussions, because I think we sometimes forget about the value of that lived experience and that camaraderie and providing appropriate solutions and next steps. So we'll have that as well in our follow-ups, those links to our virtual hangout opportunity, as well as information about the opportunities that we provide for young people to gather in person and learn from each other as well.
Yeah, so important that, especially at that age, I think, the peer-to-peer, because your peers are really your focus at that point in life. So amazing questions and discussion. I know we only have a couple more minutes. It never seems like we have enough time to get to everything, but anybody have any last minute comments or questions, panelists or participants?
I'd like to add that I'm on the other side. We've talked about young people getting free from parents or whatever, turning 69 here December, and now I'm having to bring a team back in. And like they were talking about questions before you go into a doctor, I let them know all the questions I'm asking the doctor so that they can cue me afterwards and say, what did he say? And teaching them to have a sense of what I see as important in my care, so that at whatever point I have to transition out of it and they have to be the primary people speaking, they'll be familiar with the patterns.
Thank you, Ken, for pointing that out. That's a great idea. And we didn't get to talk so much about the other end of the spectrum. It seems like it really does take a village. As much as you need to be a self-advocate, you really do need some folks for support on your team. So thank you so much, everybody, for another fantastic discussion. Thank you, Ken, for your flash talk. Again, everyone, you'll get all of the information sent to you tomorrow. And thank you, Sumathi, for a really challenging but thoughtful experience. We so appreciate it. Thank you to you all for participating, panelists and participants, for sharing your thoughts and perspectives. And we hope to see you in 2 weeks. Keep in mind, for many of us, it's a holiday weekend, I know, but I hope you'll be able to join us on November 27th. And then our final session is 1 week from that. So we don't have a 2-week space in between. I just want to let you know, putting in a plug for December 4th. So we hope to see you November 27th. Have a wonderful rest of your day, everybody. Thanks so much. Take care. And panelists, if you want to stick with us, just give us a minute here. Hey.
I've got a question. As we talked about young people, does PI and having to take infusions, et cetera, does that take you out of being able to serve in the armed forces?
Yeah, I mean, it depends. The variety, like, so the different types of immunodeficiencies, right, might either qualify or disqualify you from that. But the majority of them would be a no-go.
I assumed
the
it
risk-
would be
the
just
risk of
because of the
infection.
required,
Oh, it's the required, yeah.